Good morning, everyone. I appreciate you all being here. I'm looking forward to share my progress for over the past 3 months. Title of my PhD work is Evidence-Based Solutions for Orthodontic Acceleration. My name is Nazanin Ghods. I'm a dentist and first-year PhD student. Let me introduce my supervisors, Professor Varga and Dr. Zelish, and my methodology supervisor, David Lotsko. I would like to transform orthodontics with effective non-surgical solutions by delivering evidence-based solutions for orthodontic acceleration. As you can see, I have 2 ongoing projects. The first one started on September 2024, and the second one on November 2024. My first project is investigating the safety and efficacy of non-invasive accelerated orthodontic techniques in adolescent patients. More than 5.75 million patients only in US and Canada need orthodontic treatment. This treatment lasts 18 to 36 months with pain and complications such as anxiety, gingivitis, and white spot lesion. That's why 1 out of 4 patients decide to discontinue the treatment. This leads us to accelerated orthodontic techniques. These methods can be light-based therapies such as laser, LED, photobiomodulation. They can be electromagnetic field therapies such as pulsed anesthetic. They can be electrical field stimulation therapies, or they can be mechanical sound wave therapies such as vibration, ultrasound, and shock wave. These methods work in a way that they increase mechanical stimulation, blood flow is going to be increased, and as a result, there's going to be increasement in cell differentiation, and we're going to have healing stimulated. That's why our aim here is to identify patient-friendly, non-invasive adjuvant treatment that minimize treatment time and the risk. The clinical question here is, do accelerating methods combined with fixed conventional orthodontic treatment shorten treatment time and reduce post-activation pain? And we're hypothesizing that these methods used alongside with fixed conventional orthodontic treatment lead to faster tooth movement and decreased post-activation pain. We're using PICO framework for this project with the population of adolescent patients undergoing orthodontic treatment. Intervention group are the methods that we already discussed about, and we're comparing them with fixed conventional orthodontic treatment. We have several outcomes, which is the primary is rate of tooth movement, secondary is pain, and for the rest of outcomes, we're making sure we're covering the safety of the methods we already discussed. And clinical implications here are guideline update and increased patient satisfaction. For the search key, we conducted search key in 3 domains, and in the 3rd domain, we're making sure we're only covering the trial articles. We did the search on 3 databases, PubMed, Embase, and Cochrane Library on 14th of November. In the beginning, we had 3,518 articles. After duplication, we were left with 2,048, and after the title abstract selection, we had 274 articles. Prosper registration is done, and now we move to full text selection phase. I have 8 subcategories for my key articles, but as an example, I can show you one of them, which is vibration therapy. And as you can see, I color-coded my key articles based on red for my primary outcome, rate of tooth movement, millimeter in visit, and millimeter per month, and blue for my secondary outcome, which is pain, measured in visual analog scale. My second project is investigating the accuracy of semi and fully automated cephalometric analysis in orthodontic patients. More than 5.75 million patients annually, only in US and Canada, need orthodontic treatment and cephalometric analysis. Cephalogram is a radiograph of sagittal plane of head, which as you can see in the cephalogram, there are several landmarks. These landmarks are joined together to form planes and angles. With the help of plane and angle, we can analyze dental and skeletal relationship. This analysis can be done in 3 ways: manual, semi-automated, and fully automated. Now here comes the fun part. Imagine you're an orthodontist with 200 new patients per year. You have 2 options to do your analysis. Either you can do it fully automated or you can do it manual. If you do it fully automated, this analysis takes 30 seconds. But if you do it manual, this analysis takes 30 minutes. As a result, you will save 100 hours in 1 year with 30% less error rate. By error, I mean variability, landmark identification, and landmark measurement. which at the end, these errors will lead to inaccurate diagnostic and inaccurate treatment plan. That's why our aim here is to investigate fully automated cephalometric analysis for its accuracy and speed. Clinical question here is, does fully automated cephalometric analysis provide similar or better measurement consistency and workflow metrics than semi-automated and manual method? We're hypothesizing that these methods does provide similar or better measurement consistency and workflow metrics. We're using PICO framework for this project with population of orthodontic patients requiring cephalometric analysis. We have 2 intervention groups, fully automated and semi-automated, and we're comparing them to manual cephalometric analysis, which is our gold standard. And we have 2 sets of outcome, measurement consistency and workflow metrics, with the clinical implications of increased accuracy and guideline update. Again, I have 2 sets of key articles, one for the semi-automated and one for the manual. As an example, I can show you manual. I color-coded my outcomes based on the primary outcome and the secondary outcome, and the article that I already highlighted in the green is the article that basically compares fully automated with semi-automated and manual. For the summary, my first project is expected to end on September 2025 and the second project on November 2026. And at the end, as I conclude, I would like to leave you with a quote from the Persian poet Saadi Shirazi: "Have patience, all things are difficult before they become easy." I believe this reflects perfectly with the nature of this work, challenging in the beginning, but rewarding as we move forward. Thank you for your attention.
Thank you for the presentation, and let's see the questions. Yes, please.
Hi, thank you for your presentation. In the first project, you mentioned that you are checking the pain after the procedure is finished. Do you
Yes.
check the pain at all during the procedure?
Because of the complexity of the situation, because each patient might have a different case, that's why we're saying maybe pain, post-operative pain. Or some of the patient can be maxillofacial surgery cases. That's why measuring pain during the procedure might be difficult to estimate the pain. That's why we're thinking maybe post-operative pain. That's basically the main reason.
And because it's already a very painful procedure.
True.
So if you speed it up, you don't think that it will be more painful?
That's why we're trying to figure out. But basically, it's gonna be a questionnaire. We're gonna spread through the patients. We're gonna check the articles that how they measured the pain, and then it's most probably is gonna be based on the questionnaire, visual analog scale from 0 to 10, and then we're gonna measure the pain.
Thank you.
Okay.
So I have a question for your second topic. What is the reproducibility of the AI analysis? If you run on the same patient, it will give the same results every time, or somehow it's different?
So reproducibility itself can be a topic of a trial article or a meta-analysis, but what we can do here is basically to check articles. They might report reproducibility as a bias, and also the whole fact of reproducibility, it depends on mainly three different factors. One is landmark accuracy, that's the aim of this project. The other one can be the quality of radiograph, the quality of cephalogram that we're inserting on the software. And the third one can be algorithm that the cephalogram is, that the software is written, because there can be several different algorithms written for the project. So that what we're aiming is to find articles which the algorithm of the software is the same. So this way, the data is going to be more uniform, and then at the end, we can write in our conclusion as a limitation or as a strength for this reproducibility. But thank you for your question.
First of all, congratulations on your presentation.
Thank you.
I also have a question about your second topic. So you mentioned that you're including all orthodontic patients. Are there any populations of patients that you're planning to exclude?
We're thinking of excluding pediatric patient and maxillofacial surgery cases at this point. Pediatric patient because of the growth that they're going to have in the future and because of different anatomical landmark that they're going to have, anatomical basically radiograph that they're going to have. And the second one was maxillofacial cases because of the complexity of the case and differences that they're going to have, and also the aim of the process is different in orthodontic and cephalometric and maxillofacial cases.
Right. Thank you.
For your question.
Yes.
First of all, congratulations.
Thank you.
Use the microphone, please. Oh, the mic.
Sorry, the mic. So, congratulations, it was a nice presentation. I was wondering about your second project that maybe you've mentioned that the time factor is very important. And due to the time, basically the time-saving method is in a dental office, it's, you've mentioned something, I think, but can you just please be more specific about the time that we can save by using this method?
Sure. So I mentioned there are different, like 3 methods to do the cephalometric analysis. It can be fully manual, semi-automated, or fully automated. Fully automated is the one that takes 30 seconds. You just upload the cephalogram into the software. It gives you the result in 1 click. Semi-automated is the one that you have to upload the radiograph, and then you have to, do the measurement yourself. So obviously, that's going to take time for you to do the measurement in the computer. The fully manual is the one that takes way longer. You have to print out the cephalogram, you have to put a paper on top of it, do everything with the ruler. That's why I said if you do it with the fully manual way, it takes 30 minutes, but if you do it in the software one, which is the fully automated one, it takes 30 seconds. So basically, the number that you saw was an example calculation. As an example, if you have 200 patients in 1 year, you will save 100 hours in 1 year.